How many of you listening today are not a fan of standing hoists, having seen one too many times the horrendous use of this item of equipment? How many of you are almost emotionally scarred, having had to take away a standing hoist from a care receiver, resulting in a complete fracturing of your relationship with them? And how many of you have found that by removing that hoist, yes, you solved a manual handling problem, but you replaced it with a stress problem and used a significant amount of time and felt emotionally drained afterwards? We have, and this has been our motivation for doing this study. Our goal is to actually increase the use of standing hoists in the manual handling sector, recognising the significant benefits they have to offer a care receiver, family, and the support worker. My name is Aidan Gallagher, and I've developed Hoisted, a programme that aims to provide therapists with the skills to efficiently and effectively prescribe hoists, managing the social, emotional, and physical considerations. With Emma Small from Occupational Services, we want a situation where every prescriber of standing hoists does so with a plan, where the care receiver, support worker, and family are clear on the skills a care receiver needs to use a standing hoist, and an agreement at which the point the care receiver no longer has these skills. This study that we are going to present today is step one in the process towards this goal. This presentation was presented at the Australian Association for the Manual Handling of People, the 7th Biennial Conference in Fremantle, WA, on the 26th of May 2016. Before we start, we just wanted to give an idea of what a standing hoist is. Essentially, it's a lifting device where a care receiver is weight bearing. It's got handles, a shin rest, and a footrest, locking casters, and a sling is fitted around the torso and under the arms. Standing hoists are essentially involve an active transfer, and therefore they're really popular with care receivers because it enables them to remain engaged in a transfer process, and therefore there's less focus on disability. They're also really popular amongst caregivers and caregivers and family members, mainly because standing hoists facilitate dressing and undressing and standing, and they really simplify tasks such as toileting, as they eliminate this need for a care receiver to be moved on to a bed for these tasks. This versatility and efficiency and the reduction in manual handling make them an attractive option compared to that full lifting hoist alternative. And just because you essentially there's a reduced amount of manual handling, there's also the reduced cost of care for the care receiver. Whilst standing hoists have a significant number of advantages, they do present risks when used inappropriately. A report from the National Health Service in the United Kingdom reported 15 falls from hoists in the past 4 years, some of which were attributed to standing hoists. I was not able to get the specific data for Australia, but I suspect there's a certain level of underreporting in relation to these items of equipment. Standing hoists are regularly recommended in a rehabilitation setting when a participant has just not quite reached the rehabilitation goal of sit to stand independently. So a standing hoist involves certain skills that a participant needs to be able to bring to the table, and when they don't have those skills, the support worker would assist. What is interesting is what happens in a rehabilitation setting in relation to the assistance, as it usually is provided by allied health professionals. A study by Darrow and colleagues discussed a really different culture amongst allied health professionals from nursing staff in terms of manual handling and subsequent musculoskeletal injuries. Within these therapies, the physiotherapies, the occupational therapies, the goal of treatment is essentially to rehabilitate and promote independence. This can mean challenging patients to step beyond their capabilities with an aim to restore function. A component of this can involve weaning participants off equipment as soon as possible. transfers supported by a health professional as opposed to using equipment are sometimes perceived as more rehabilitation focused and so more patient focused. And this is the case, a standing hoist can be seen as a lesser marker of disability than a full lifting hoist. This study, again by Dara and colleagues, talked about allied health professionals often being responsible for training staff in good biomechanics. Therefore, there is a perception that good biomechanics can avoid injury, although this assumption has been refuted in the literature many times, and most famously by Maris in 1999. Um, Dara concludes that a patient is still considered the prime focus of therapists as opposed to the self-care of and maintenance of health of the actual therapist. So standing hoists are sometimes prescribed in the hospital with the allied health professional being that support worker. It then goes out into the community with the expectation that the support worker will continue this intervention without someone specifically advocating for the without someone specifically advocating for the client. This help a support worker is required to give can represent this bottomless pit. So uh, so we usually get a therapist involved advocating for the clients with the rights and dignity of the participant at the fore, and the use of a standing hoist can often result in this kind of standoff between the treating therapist and a manual handling advisor. And the debate can bounce between the rights of the support worker to remain safe at work and the right of the participant to continue to exercise their right to rehabilitation to use a standing hoist, recognising that if they don't stand, that idea that if you don't use it, you lose it. What can happen is there's no clear line for when a standing hoist is unsafe, and not only for the participant, but also for the support worker. And we've seen too often the result is an exceptionally emotional day for the participant, the support worker, and the therapist that goes well beyond the day. Um, Therapists coming to my workshops describe being traumatized at times at the process of removing a standing hoist from a client, and some having sleepless nights wondering, are they going to get a call about a client who fell from an item of equipment they prescribed because they were aiming for this rehabilitation goal. They are therefore polarised, going from hating standing hoists and refusing to prescribe them to loving them but dreading the day when they need to say no. There's a significant lack of guidelines on standing hoists, keeping the support worker and the participant safe. In fact, it's almost impossible to get anything written on standing or active hoists in the literature. It's an area that's really starved of research, and Emma Small and I, we thought we talked about it long enough when we said we were going to try and do something about it. So essentially, we wanted to ask the question, what skills does a care receiver need to display for the use of a standing hoist to be safe for a care receiver and the caregiver? We decided to use a Delphi style study. And what a Delphi study is asking expert panel to give their views on a phenomenon. We did this in terms of an online survey, and we sought permission from the chair and executive committee of the Australian Association for the Manual Handling of People, as that were our participants. As the Australian Association does not have a official ethics committee, we did undertake the ethics process using the Declaration of Helsinki as a guideline for which outlines what is ethical practice in research. So we had three parts of the study. We had an open-ended exploratory survey where we asked an open-ended question. Then we analysed the results of that, and we came up with 29 criteria for use of a standing hoist, and we wanted to explore the measurable range within those 29 criteria. And then we wanted to explore the importance of each of those 29 criteria, i.e. which were desirable and which were essential. So in stage one, the two questions we asked were identify all the skills you feel a care receiver needs in standing hoists during to ensure the health and safety of caregiver and care receiver. Identify all the skill deficits a care receiver would display for you to conclude standing hoists are unsafe for caregiver and receiver. We used the two sides of the question because we felt a participant would perhaps identify skills, but they might be better able to identify when a skill wasn't there. And that's why we use those two questions. The analysis we used was, again, it was qualitative methods. We used we divided the data into themes and sub-themes. We did that individually, and we consulted on what we found, and we came up with 29 criteria, and we used the complex of reflexivity, and this was used to control for research bias because, again, Emma and I have experience in the clinical side of this area, and we really wanted to make sure that our clinical opinion wasn't driving what would come up in those 29 criteria. In stage two, we wanted to explore the range, and to give you an example, we wanted to come towards some kind of measurable criteria. For example, weight bearing. We divided weight bearing into the minimum time, the minimum percentage of weight bearing, and the minimum number of legs we would expect the care receiver to be able to weight bear on. In stage two, again, it came down to quantitative methods, and we used descriptive statistics by which to analyse the results. Stage three, at those 29 criteria, our aim, which again we didn't get to this stage, was to identify the desirable and essential skills from the data.